Dear participants, this is the housekeeping announcement. Our symposium session will start soon. This is meeting room 3 for Symposium 3 Psychology. Thank you very much.
Okay. Hello, everyone. It's a nice afternoon, right? Today is a 2020 Rebound Symposium and video meeting. This is Symposium Workshop 6. The main topic is psychology. And my name is Yang Qizhen, the Associate Professor of Department of Psychology, National Chengchi University in Taiwan. And today it is my great honor and pleasure to be here to use this kind of video meeting to share all of our speakers' works with you. And I believe this symposium is a very interesting topic across different areas of psychology and very hot topics and very great topics, and can give you very informative ideas about psychology. And let me give you a brief introduction about these 4 topics. The first one is me. I will talk about the consistency and the persistency of psychological service in community and home-based palliative care. This is a kind of different view of psychological service in Taiwan. So I will share this kind of psychological services with you. The second one is also my colleagues, Professor Wu Zhixun, and he's a health psychologist. He will share the psychological profile of Taiwanese with subjective cognitive decline with you. We all know subjective cognitive decline is a very hot topic in dementia care. And because he is a health psychologist and he collaborated with neuropsychologists all the time, and he will share his new ideas about subjective cognitive decline with you. And the third one is also one of my colleagues, Professor Xu Yanxuan. She's from the Department of Psychology, National Chongcheng University in Taiwan. And she is a clinical neuropsychologist, and her expertise is in clinical neuropsychology and especially in Alzheimer's disease and dementia care. And she will share the neuropsychological diagnostics and the cognitive intervention in individuals at risk for dementia with emphasis on prospective memory. I think it's a comprehensive topic about intervention and dementia care for Alzheimer's disease, and especially she introduced a special topic about prospective memory. It's I'm very looking forward to it. And the last one is Dr. Edward Mullen. He's from Australia. He will introduce a classical topic about psychiatry, the association between psychosis and borderline personality disorder. And he will introduce the old concepts and the new treatment pathways. I think it's also very interesting. So let's just start our session, and each of our speakers will have about 20 minutes to share their ideas, and we will left about 10 minutes around to QA. So I will be the first one, so I will just share my PPT with you. Okay, my topic is about sprouting the consistency and persistency of psychological services in community home-based palliative care. I think this is before I start this topic, I will briefly introduce the psychologist, the history of psychologists in Taiwan. Not too long, so don't worry about that. The Psychologist Act is from 2001, November 21st. And from then since then, it has been almost 20 years. And from that time, in Taiwan, we started to establish a license for psychological services. Actually, we got two kinds of different psychologists. The first one is clinical psychologist, and second is counseling psychologist. Indeed, uh, uh, in 2020, I think it's almost 2,000 clinical psychologists in Taiwan and almost 4,000 counseling psychologists in Taiwan. And like all psychologists in the world, psychologists do a lot of individualized psychological services such as psychological assessment and psychotherapy. And they work in different kinds of clinical settings, different kinds of departments such as psychiatry department, rehabilitation department, neurology department, or even family medicine department. So psychologists in Taiwan has worked widespread all kind of different services. Even we have our own so-called psychologist clinic. So you can just go into a community and find some kind of outpatient clinic and find a psychologist in Taiwan to solve your psychological problems. So it is really developing field in Taiwan. But today, I will introduce a different kind or different view of psychological services in Taiwan. I call this a hospital, community, home connections because we know psychologists always did their clinical service in a small room and with individuals, and usually we just solve the one individual's problems. But in hospital base, we can only solve their problems at that settings, and we can never know about their livings and their daily livings and their lives. So, but many people with psychological problems not so severe that they need very intensive psychotherapy or very intensive psychological services. Many people in the community or their home may need a very minimal or many mild psychological services like professional emotional support, like just a kind of health education about the specific topics about of psychological disorders. So because of this reason, in about 2 years ago, 2 to 3 years ago, I started to collaborate to connect different psychological services in between hospital, community, and home. Try to make these all three situations together. Try to put them together to form a connection between this kind of different services. So, in terms of the procedure. Today, I will take the palliative care as an example because we're talking about end-of-life care. It's a very comprehensive and integrated medical service or psychological service. We will do the end-of-life care or palliative care in the hospital, in a ward, and we also can do a palliative care in a home setting, and we also can educate people in the community about death and life. So palliative care is a very good example to show you this kind of connection or coordinated psychological services. Basically, we can accept the different referrals from different resources. And for example, we will get some referrals the patient or families who needs the psychological service from the home visits. Our psychologist will visit them at home. Or we can get the referrals from the medical care teams. Or we can get the referrals from case managers. And even patients and families themselves, they can just directly ask for their for our psychological services. And after we get these referrals, and our psychologists will evaluate their emotional distress and emotional problems, and discuss with medical teams and even patients and families, and to decide whether they have the psychological problems or any kind of needs of psychological services. And after the evaluation, we will if they did need psychological services, we will continuously and persistently care them even at home, or just introduce them to the outpatient clinic to do the intensive psychological services. So this whole procedure will make the palliative care not only in the hospital and even at their home and at the community and at the community-based outpatient clinics. And we did this palliative care or coordinated services based on the three-level psychological intervention. I think it is well known for you, and primary, secondary, and tertiary intervention. And specifically, we did this in community, hospital, and home. In terms of the primary interventions, the main target is the healthy citizens and healthy people in the community. We do a lot of work about death literacy, and recently we do a lot of work about advanced care planning, which is a kind of advanced decision and you can make. And when you face a very severe medical conditions such as unconsciousness and vegetative state, and you can decide whether or not you will accept the kind of CPR or any kinds of life-sustaining procedures. And we call this advanced care planning, ACP. And we even did some health education in high school sprouting, high school students. Recently, the last year actually, I trained a group of undergraduate students and to establish or to develop a kind of course about end-of-life care. And I asked them to go into the junior high school just near our, just in the neighborhood of our university, and they will teach them, use the friendly, high school student-friendly course, teach them about the end-of-life care, and let them to talk about the end-of-life care in a comfortable way with their parents and their grandparents even. So this kind of high school sprouting to incorporate the end-of-life of palliative care into the high school students and their families. So the education is a very important part of the primary intervention. And we also did the health education and this kind of primary intervention in the activity center of the community. In that activity center, our psychologists developed a series of death literacy courses and the pre-ACP consultation courses. And we use about 4 weeks, once at a week, and we talk about the ACP and death literacy with the people, especially elderlies in the community who just joined the courses of in the activity center. The feedback is good. They just like to talk about the death and life. And of course, we use a very comfortable way and a smooth way to talk about life and death, not directly say about death, okay? But their feedback is good. They even want to talk about with their children and their deaths and their lives. Okay? So primary intervention is very, very interesting experience of our psychology to do the minimal or basic psychological services with them. And in terms of the secondary interventions, we focus on the early detection about emotional distress in the community or in the hospital. And we develop some kind of we use different kinds of techniques or questionnaires or structured semi-structured interviews to detect the high-risk people with emotional distresses. And we also collaborated with medical teams, including physicians and nurses and social workers, to go together to intervene the families and the patients. to know or to discuss their emotional distress, specifically. And we also do the home visit works, and we directly go into their homes and try to know their emotional distress. And we found interesting things, which shows that people at their home, at the beginning, they do not want to talk about their emotional distress all the time. They just focus on life or death or medical conditions about the patient. But along with the time, and you continuously and persistently care them, and they will talk about their emotional distress with you even after patient's death. This is we so-called the bereavement counseling of after-death caring. Okay? And after the secondary intervention, we move into the tertiary intervention. We mainly focus on patient and families, of course, and the tertiary intervention is usually what we do and what we expert to do this. And we do this in different settings, like home visits, like activity centers, and OPD, outpatient clinics. We do the individual psychotherapies, and we do the group therapies or group counseling, and we do the professional emotional support and stress coping techniques. So the main point of these three different levels of intervention not only focus on each level of their interventions. The most important one is the connection and coordination between hospital, community, and home. And these three kinds of different interventions. We use the same psychologists, we use the same team and try to make them together, to put them together, allow the patient and families consistently accept a very stable psychological services. Okay. And more than that, we also did the fourth level intervention we call the bereavement counseling for palliative care. Actually, we try to separate different stages for end-of-life care, which is a stable stage, close to death, acute bereavement, and complicated bereavement stages. And we also do different kinds of psychological service in each stage. And interestingly, I just introduced the interesting part. And interestingly, we separate the bereavement stage for two, the acute and the complicated bereavement, because many people face the death of their loves, usually feel depressed or anxiety or lost or frustrated all the time. So in the stage of acute bereavement, the intensive psychotherapy or psychological treatment may not be really needed. What the important in this stage is about the consistently emotional support or accompany. So our psychologists do a lot of accompanying works with them at this stage. But if you go into the complicated bereavement stage, you may need the intensive psychological services, especially individualized psychotherapy for specific persons. So we provide the outpatient clinic, and we provide the psychotherapy just near their where they live, and make the psychotherapy very easily to get. Okay. So the whole fourth level of intervention, just like this procedure. So a home-based psychological palliative care based on person-centered relationship, and we always focus on the relationship and the quality of the relationship by a very, very professional emotional support and accompany. And then we do the bereavement counseling and the, in different stages after the patient's death, and even we do the psychotherapy. And the most important is we following this procedure and following this concept, the coordination concept. I try to make a network of mental health. This is not so new, but in my experience in the last 3 years, this is very useful to if you want to establish kind of a systematic or holistic support or psychological service for people in community, and they also go into the hospital for some kind of psychological problems. So we got 4 levels: primary, secondary, tertiary, and end of life care, and we got 3 different fields: hospital, community, and home. I have to apologize that some Chinese words there, but this just indicates some specific works we do. The important part is we form a network, and this network can just accept or to catch the psychological problems in community-based people. And if you want to complete this, I think the family-based psychologist is very, very important. And this kind of family-based, not hospital-based psychologist will connect different psychological services and based on the step care model. This model is from UK. It's talk about a different group of patients or different group of citizens will accept the different kinds of level of psychological services. And the other point is we will make a kind of case management system and allow the psychological services can well coordinated with other systems such as medical systems and nursing systems and social worker system, and put all systems together will start to let the patient and families in that network. And if you want to do the psychological services, you will follow this lifespan services model. And from normal to abnormal, all the psychologists can do different kinds of work, including dementia, including ACP, end-of-life care, parent-child relationship, psychological traumas, long-term cares, even traditional psychiatric disorders. So this kind of connection and coordination, once again, I will emphasize on that, and this is very important about these connections. This is a practical note of our psychological services. We introduce the schedule and the part of our services and the time and people our services in this note, and we will let this kind of note into the community and home and let them more closer to the psychological services. This is an example of our psychological services in outpatient clinics. Actually, we got 12 different clinics in Taipei City because we have 12 different districts in Taipei City. And each district will also provide the psychological treatment services. And this is our surface map of you can see all the Taipei City. This is a map of Taipei City. You can see from the mountain to the river, our psychologists go around the whole Taipei City. And this is a very, very simple data about our psychological services. You can see we can make a home visit. We can make 103 home visits per month. The data is from 2008 and 2019, 18 and 2019. So the needs of the home visits or this kind of coordination is very high. And this is what I want to establish and still developing is kind of this connection. We try to make the different care, different psychological services together, including dementia, long-term care, and psycho-oncology into the outpatient clinic services and even into the hospital-based ward care. So this is about the connection and coordination and collaboration. Thank you for your listening. Okay. I think we will start. We will start the QA at the last. So let's start the second presenter, Professor Wu Zhixun. I give a video meeting to him.
Can you hear me?
Yes.
Thank you, Professor Yang. And hi everyone. I'm Wu Zhixun from the National Zhengzhi University. And as the chairman Yang just said, I'm a health psychologist, and my main interest is in geropsychology, that's the psychology of the aged. So the topic today I want to share with you is the psychological profile of community-willing Taiwanese with subjective cognitive decline. The research background is that subjective cognitive decline was highly related with Alzheimer's disease. And some of the older adults with the SCD might be at the stage of preclinical Alzheimer's disease that's proposed by some of the scientists. And in the group of the Subjective Cognitive Decline Initiative, they suggest that SCD should be treated as a diagnostic. But I was wondering that if this is right, because subjective cognitive decline is defined as a subjectively person feel like memory or cognitive function is becoming worse, but without objective evidence of cognitive impairments. That says their cognitive were normal, but they think they're having some cognitive problems. And we all know that if you're worrying or you have lots of emotions, something like anxiety or depression, you may have that kind of feelings. So I was kind of wondering if SCD is a real thing, that we should think it as a preclinical stage of Alzheimer's disease. And the SCDI, they proposed that as a research definition of SCD is that you have to self-experience persistent decline in cognitive capacities in comparison with a previously normal status and unrelated to an acute event. And it's a normal age, gender, and education adjust performance on standardized cognitive tests. And those were used to classify MCI or prodromal ADs. And the exclusion criteria is that MCI or AD or dementia should be excluded, and they cannot be explained by a psychiatry or neurological disease or any other medical disorders. If they do, they won't define as SCD. But Jensen, one of the leading figure in the SCDI, proposed that in 2020, this year, proposed that maybe that SCD should be divided into three kinds. The first kind is a reversible SCD. They don't have any objective cognitive decline to any level of impairment, and their conditions underlying that may be including depression, side effect from medication, or intermittent sleep disturbances, which means that they won't grow into dementia. And the other kind is stable, non-reversible SCD, and they think that may be a normal aging process that can be an underlying cause of this type, and which means that they won't grow into dementia either. And the last one, the C type, is that SCD with subsequent progressive cognitive decline to impairment or dementia, and they will grow into dementia. And this type is what we are thinking about. That's the most important type, that we need to define them or to identify them to somehow prevent them to grow into dementia. But if we assess at this part of the stage, we won't tell the difference of them. So if we ask them if you have any subjective cognitive declines, they will be the same. We cannot tell the A group, B group, or C group at the beginning of the SCD. So I was kind of wondering, what are the characteristics of people with subjective cognitive decline? Are they more depressed, anxious, or worried? Are their attitude toward aging more negative and less positive? Do they have poor quality of life? And furthermore, maybe having SCD is a moderator, moderating the relationships among attitude toward aging, emotions, and quality of life, which means that I don't want to think SCD. I don't want to use SCD just as a diagnosis to tell the difference, but I wanted to think them as a whole. Those who reported they have subjective cognitive problems we should care about them. Yeah. So the methods that we run a research, and we include those with non-demanded community dwelling adult age 55 or above, and we exclude the following: those have mental illness, neurological illness, substance use or abuse, or communicating problems. And the ways of recruitment that we use a convenient sampling by giving out flyers and snowballing. And you can see just as the picture, we use a community room to do the assessment. And the place of recruitment is including this something from a volunteer group, share meal events, health center, hospital voluntary group, and activity center of public housing. And the major is including the one that Jensen they proposed. The main question is, do you feel like your memory is becoming worse? And we also asked the following that was suggested to coding in studies on SCD. And we use many kinds of neuropsychological tests to do the screening of the cognitive problems. And it's including the screening, memory tests, attention and processing speed, executive function, and daily functions. And we also measure psychosocial aspects. We use BDI, BAI, and the Penn State Worry Questionnaire, Taiwanese version, to evaluate emotion. And we use the Taiwan Attitude Toward Aging Questionnaire to measure attitude toward aging. And we use the WHO QOL brief version to measure the quality of life. And the procedure was as follows. First, we let them sign the informed consent, and we do the basic interview. We assess the STD features, and we do the neuropsychological tests, and we do the psychosocial evaluations, and then we have a time for them to ask questions about the whole evaluation. It took about 2 to 3 hours to finish all those. And about analyzing, we first grouped our subjects into these 3 groups by the 2 criteria. Those we grouping into cognitively normal group is they have to have no more than 1 test score below 1 standard deviation in any cognitive domain. And they answer no to the question, do you feel like your memory or cognitive function is becoming worse? And for those who we group into SCD group, they have to answer yes to that question. And they will have no more than 1 test score below 1 standard deviation in any cognitive domain. And for those we group into MCI, they have to have 2 or more tests score below 1 standard deviation in any function domain, and their daily function is not significantly impaired. And we use ANOVA to comparing group difference, and we use past analysis by multi-group SEM, structure equation modeling, to exploring the moderating effect. And we use IBM, SPSS, and ALMOS to do that. And here's the results. We totally include 243 participants, and of them, 133, 55% were cognitively normal. And 51 of them was grouping into SCD, and 59 of them is grouping into MCI group. And we can see the group difference here. This table is for the cognitive function. And you can see that most of the significance is between cognitive normal and cognitive normal, SCD, and the MCI group. The cognitive normal SCD, they don't have any significant difference between on any kind of cognitive test. And you can see that cognitive normal group was a little bit younger than the other 2 groups. And this is the psychosocial part of the measurement. And you can see that the SCD group was more depressed. If we use BDI to measure, it's significantly more depressed than the MCI group. And they were more worried than the normal cognitive group. And about attitude toward aging, you can see that SCD group was higher in negative attitude toward aging than the cognitive normal group. And while to the quality of life, you can see that at the physical and psychological domain of the QOL, the cognitive normal group was significantly higher than the SDD group. And we use this model to do a past analysis, and we propose that attitude toward aging can affect worriness and BDI, which represent depression, and then to affect quality of life. And we use a multi-group method to do that. That means we divide it into the cognitive normal group, SCD group, and the MCI group to analyze to estimate all these parameters. And the model looks like this. And you can see that the red line is a significant line with a negative prediction. And the black line is a significant prediction, which is positive. So you can see that for those who were cognitively normal, if they have higher negative attitude toward aging, it's directly negative predicts poor quality of life in all 4 domains. And the negative attitude could go past depression and still predict the all 4 aspects of the quality of life domains. And the positive attitude, it has a negative prediction to worry, and they have a direct prediction positively to psychological aspect and environmental aspects of the QOL. And as to the SDD group, you can see the line is much more simpler. And the negative attitude toward aging only have one significant prediction, is to the depression. And which means that if you have higher negative attitude toward aging, you will be more depressed. And if you are more depressed, you will have lower psychological, social, environmental quality of life if you are in the SDD group. And you can see that positive attitude toward aging is a more significant predictor here. It can negatively predict depression, which means if you have a higher positive attitude toward aging, you will have a lower depression score, and in which it predicts a lower quality of life. And the positive attitude toward aging have a direct effect to psychological, social, environmental quality of life, which if you have a higher positive attitude toward aging, you will have a higher psychological, social, environmental quality of life if you're in the SCD group. And as to the MCI, you can see that the positive attitude only have direct predictions to all 4 aspects of the quality of life, but the mediating part was gone, not in the MCI group. And if you see the MCI group in the negative attitude toward aging part, you can see that it still can predict the depression, but the depression only can predict social aspects of quality of life, but not others. And it directly can predict environmental aspects of quality of life. Okay, so it comes to the conclusion. What are the characteristics of people with subjective cognitive decline? We can see that as a double check that no significant difference between SCD and the cognitive group on any neuropsychological test, which means or which can represent they don't have any difference between cognitive functions, which is the definition of the SCD. And people with SCD had higher scores on worries, depressions, and negative attitude toward aging than the cognitive normal group. People with SCD had lower scores on physical and psychological domains of quality of life than the CN group. And if we see the past analysis, we can see that it do have a moderating effect of the groups for SCD, MCI, and the cognitive normal. And you can see the lines that for those who were in the SCD group, the positive attitude toward aging might be a good predictor for their quality of life, and maybe is mediated by the depression part. So if we think about that, those who were SCD, if we don't divide them, we can't predict them if they will grow into depression, dementia or not. We still can say that they maybe need more positive attitude toward their aging. If they're higher in those, they may have a better quality of life. So that might be one of the points that we can think about SCD. And thank you.
Okay, thank you, Professor Wu. And let's move to the third presenter, Professor Xu. And she has already provided the video and maybe our housekeeping.
Yes, we are now playing the video.
Okay, thank you.
Hi everyone, my name is Xu Yanxuan. I'm from National Zhongzheng University in Taiwan. I've been wondering about why we forget to do things so often. As I grow older, I tend to forget more easily about things I promise others to do. That's quite embarrassing a lot of time. The client referred from memory clinic to me also very often complain about being forgetful. Sometimes they say they will forget about things that has happened before, but a lot of time they also complain about they will forget an appointment with their friends. However, in clinical routine, we very rarely assess patients' ability to remember to do something, the so-called prospective memory function. So, here I want to talk about what happened when we test people at risk of dementia with prospective memory test. So, what is prospective memory? By definition, it is the memory of an intended action to be performed in the future. It is very important for human goal-directed behavior, and research also show that prospective memory deficit posed more impact on caregivers' well-being than episodic memory deficit. Prospective memory can also be divided into at least two components. One is the retrospective component. This is very similar to what we know about episodic memory. While in the case of prospective memory, retrospective component refers to the content of the intention, which means what we're supposed to do. On the other hand, prospective component is the part that is specific to prospective memory. It is the part that makes prospective memory different from episodic or semantic memory. Prospective component refers to the realization that something has to be done at a specific moment. So it does not concern the content of the intention. It is about if we know that at this particular time, there is something that I need to do. Because it is quite mouthful, so in the subsequent talk, I will refer to prospective memory as PM. In a typical prospective memory test, the participants are instructed to form an intention. This intention needs to include a PM cue that indicates the correct timing for the PM action. And it also needs to include a PM action that is going to be performed. For example, if we tell the participants to tap the table when I ask about their birthday, then the moment when I ask about their birthday, it will be the PM cue, and tapping the table will be their PM action. After the intention has been formed, there has to be a delayed period when the participants are told to do other irrelevant activities until the PM cue occurs. This is often called the ongoing task. The PNQ can be an event, such as when I say cheese, or it can be a time, such as at 4 p.m. If one can successfully detect the occurrence of a PMQ, then they can start to recall the content of the intention, which means they have to remember what needs to be done. After all this process checked out, one still needs to put away what they were doing earlier and shift their attention to carry out the PM action. And then we will collect a PM hit. The process model proposed by Kliegel and Associates divided all this process into 4 stages. As we can see, each stage requires support from various cognitive activities. So, back to my questions. Do people on demanding process showed PM deficits? Apparently, yes. There is empirical evidence showing that individuals with mild cognitive impairment performed worse on PM test. And there are also longitudinal studies showing that patients with Alzheimer's disease already have poor prospective memory performance at preclinical stage. There are also studies shows that APOE4 carriers perform worse than healthy controls on PM test. But how do we measure PM in clinical settings? In the following session, I will talk about 3 tests that we have used in our research and clinical experience. The first PM test we tried to use was the Cambridge Prospective Memory Test, developed by Dr. Wilson, originally for people with traumatic brain injury. This is a standardized clinical battery that comprised of 6 PM tasks, with 3 event-based and 3 time-based tasks. We found that people with MCI performed significantly worse on these tests as compared to healthy controls, regardless of the type of the cues. These tests assessed how many PM hits a participant can achieve. However, we are not sure about on which stage of the complex PM process has been compromised in this group of people. My student recently adopted another type of PM measures, the Modified 6-Element Test. This test was originally designed by Dr. Schellis to assess executive function, and then modified by Dr. Kliegel and his associates to measure prospective memory. So we can see that this test will put more emphasis on the ability of planning. The modified SED test has only 1 PM target, but it mirrors a scoring system that corresponds to the process model, including assessment of performances on 4 stages. Participants are told to initiate a PM task when encountering a cue item while they fill in a questionnaire. The PM task has some rules, and the goal is to achieve maximum scores. The participants are told to plan for how they will proceed once they have started the PM task. Performance will be rated according to each PM stage as proposed by the process model, as can be seen on the screen here. The results show that as compared to cognitively healthy adults, participants with MCI performed worse on the intention formation and intention retention stage, which means that in the very beginning stage of PM, they already showed deficient ability in planning for a complex task they are about to take. They have poor plan elaborateness and have more difficulty remembering the specifics of the plan they just made. So, the next question is, how early does this PM deficit start to show? We're familiar with the concept of MCI, which is a pre-dementia stage when the participants' activities of living has not been compromised, despite their evident cognitive deficits. However, recent studies starts to pay more attention to a pre-MCI group where they address subjective cognitive decline but performed within normal limits on neuropsychological tests. Studies have shown that this group of people have higher rates of conversion to dementia, and they also found pathological signs of Alzheimer's disease in these people's brains. So we are wondering if a PM test would be more sensitive to their subtle cognitive deficit than conventional cognitive tests. In another study, we tested the sensitivity of PM tasks in people with SCD and a matched group without cognitive complaints. Participants were simply asked to perform 2 tasks. In the telephone test, they had to remind the examiner to make a phone call 5 minutes after the instruction was given. And in the envelope test, participants had to remember to seal the envelope with a round sticker of a specific color when they are given an envelope. The results show that people with SCD performed significantly worse on the time-based PM, and although the subject number was small, but we can see there's a large effect size. And when we see closer into the percentage of the participants' performance type, then we'll see that 71% of the participants with SCD showed no response as time goes by, but only 35% of healthy controls completely failed in this task. As far as we're aware, this is among a few studies that investigate PM function in people with subjective cognitive decline. And we found corroboration from Raven, their study published in 2014. We're not aware of the existence of this study when we started conducting our own, but we're very happy to find that there are other study results show that PM test might be sensitive to the very early stage that precedes dementia. Why is PM sensitive to pathological change? From a cognitive perspective, some say it is because PM lacks of contextual support, so it would rely more on our self-initiation ability. I think this is also one very special part about prospective memory test, because most of the neuropsychological tests do not test this ability. Usually participants are referred to assessment room, and then they start to behave in a very structured environment. Usually they were told to do certain things. The behaviors are carefully elicited to observe if there is any consequences of brain injury, and the participants have very little opportunity to initiate things on their own. However, in a PM task, they were told to do something, and then just the intention seems to be set aside, and then we will silently or sneakily observe if they will remember, if that intention will come up later on. So I think this is one very special part about prospective memory that could possibly be complementary to conventional neuropsychological tests. And why is PM more sensitive to SCD? We think it is likely to be a result of reduced cognitive resources. Some functional imaging studies have shown that in people with SCD, they recruit more neural resources during cognitive tasks so that they can maintain their normal performance on behavioral tasks. So we figure it is likely that in a complex task like PM, participants may show performance decline more easily because it requires additional attention resources to put it over. However, it is also likely that PM deficit is simply more noticeable due to its greater functional impact to our daily lives. And so the participants we recruited, the participants who complained about cognitive decline, were those who performed worse on PM tasks. And at a neuron level, we think PM deficit may be related to an impairment of functional connectivity, and we will talk about this later. And why is the time-based PM more sensitive to SCD? We think it is because of the additional requirement of self-initiation ability that the time-based PM task call for. At least in our study design, the event-based task has a trigger that may trigger a response from the participants, while the time-based PM did not have one, so the participants were on their own. I think there is no doubt that PM test can be used to do cognitive profiling for our patients, but if we want to go one step forward to consider it as a test for early detection, we need to know more about its neural basis. Literature is largely concentrated on the role of rostral frontal cortex, the Broman area 10. It is considered a gateway to direct our attention inwards or outwards. And the lateral part of Broman area 10 is considered particularly important to the ability of maintaining an intention. In addition to Broman area 10, many cortical and even subcortical areas have been reported to be related to PM function. So, PM should be considered a functional system, as we know that PM relies on supports from various cognitive processes, and it also concerns the activations of multiple brain areas. In this sense, connections between the distributed anatomical sites will be critical to prospective memory. Studies on healthy adults have shown that PM may be relied on the functioning of frontal-parietal network. The dorsal frontal-parietal network may be more related to intention maintenance and strategic monitoring of cues, while the ventral one may be associated with a spontaneous intention retrieval process, at least in some type of PM task. However, there has been limited studies about how structural connectivity may affect PM performance in patient groups. As can be seen here, we've only found a few studies in the literatures that studied how structural connection may affect PM performance in patient groups, such as those with diffuse axonal injury, pediatric TBI, and HIV infection. So we adopted the same DTI technique as these previous studies used and analyzed the microstructural integrity with tract-based spatial analysis in people with MCI and SCD. We found two places particularly important for the participants' PM performance: the corpus callosum and the superior longitudinal fasciculus. We found that the participants' performance on the event-based prospective memory task was particularly associated with the left superior longitudinal fasciculus and the genu of the corpus callosum, while their performance on the time-based PM was more associated with structural integrity in the right superior longitudinal fasciculus. This finding indicates that PM relies on the integrity of interhemispheric commissural fibers and association fibers that connect the frontal lobes with the posterior brains. I've been advocating the use of PM in evaluating people with a risk of dementia, but a very often question is, AD is a disease starting from mesial temporal structures. PM does not particularly rely on hippocampus. And yes, I concur. However, there are also studies questioned the validity of amyloid cascade hypothesis, and some propose that AD may be considered a disconnection syndrome. The picture on the right side of the screen showed widespread white matter reduction in MCI, and we can also find some studies arguing that this is not merely a result of Wallerian degeneration. In the last part of this talk, I want to talk about how we can promote prospective memory. This is quite important as we know that PM affect our daily lives a lot. And there are several ways. The easiest way is to use an appropriate external aids, like we all do. Like I use Google Calendars, otherwise I wouldn't remember what I'm supposed to do today. And another way is to do a process-based training. This means that we can train those basic cognitive abilities that underlies prospective memory. For example, we can do attention training or we can do a memory training. It depends on which component of the participant had problem with. I want to talk more about the third way is to induce a specific internal strategy that is specifically developed for promoting prospective memory. It is called implementation intention. The idea was adopted from Goal Wizard, who described some methods to facilitate goal attainment. And when it is applied to PM, we simply need to form an internal sentence that combine the cue and the action of our intention together. So, for example, if I want to go get some pills later, then it is better that I can form a sentence that tell the specifics of the trigger and the exact action. So I might say to myself, when I left this chair, I will go get my pills in the closet, or something like that. And there have been many studies on young and old adults, mainly healthy adults, showing that this method could enhance the chance of successful PM hit. However, studies on MCI has been very limited. My students recently tried to apply this technique to people with MCI. She recruited 30 participants. Half of them were assigned to a standard instruction condition, and the other half received the implementation intention training. She adopted the Einstein-McDaniel paradigm to test PM. I will skip the detail of the task and simply put that it was a computerized PM task that can measure reaction time. The results show that participants who received the implementation intention instruction performed significantly better on the PM tasks as compared to those in standard instruction condition. Although the sample size was small, but we can see the effect size was quite large. There has been debate about the mechanism of this strategy. Some said implementation intention changed the participants' attention allocation policy. So they put more cognitive resources into PM task to achieve a better performance. But if this is true, the participants will suffer from a performance cost in their ongoing task. In this study, we compare the two different instruction groups. The induction of implementation intention did not increase reaction time during ongoing task, which means there was no performance cost or there was no penalty on the attention resources available for the ongoing task. So, we believe the implementation intention works by enhancing the binding between the PMQ and action. By forming the internal sentence, we try to enhance this binding strength. In this way, the PMQ becomes more likely to be triggered upon encountering the cue. And the locomotive process could also offload some cognitive demands, making PM performance less vulnerable to resources depletion. The studies I presented here suffered from quite a amount of shortcomings, such as small sample size, cross-sectional design, inadequate biomarkers, and inconsistent diagnostic criteria. So results await corroboration from future studies. Currently, we're still working on some derivative PM studies, and we're modifying PM task parameters. We include resting state functional MRI techniques into our study, and we're testing different kind of cognitive intervention approach. And we're also studying PM in other pathological conditions such as cerebral small vessel disease and people with cancer-related cognitive impairment. To sum up, PM is susceptible to cognitive deterioration, and specific types of PM measures showed potential in cognitive profiling and early detection for some pathological conditions. Successful PM relies on functional integration of the brain, while the neural underpinning remains to be clarified. And behavioral intervention of PM has been proven effective, and it is paramount due to its functional relevance. Here, I want to thank for all my research associates. They have offered a lot of help and valuable insights during the process, and without them, none of this could be done. And thank you all. Please let me know if there's any comments or feedback or questions. Thank you.
Okay. Okay, thank you. Thanks, Professor Xu. Please close the video. Okay. Okay, move to the last speaker in this session, in this symposium. We welcome Dr. Edward Mullen from Australia and introduce the psychosis and borderline personality disorder, old concept and new treatment pathways. And we give the session to Dr. Mullen, please.
Dasha Hao, thank you very much for the invite to present at this conference. Can you hear me okay?
Yes, good, very good.
Excellent. So my name is Dr. Edward Mullen. I'm a consultant psychiatrist specializing in youth mental health and severe personality disorders, and I'll be presenting some information and a couple of studies about BPD and psychosis. So for introduction, I'm just going to give a little bit about sort of our current thinking about BPD, and particularly in youth, talk a little bit about sort of what we know about BPD and psychotic symptoms, and present the findings of a recent study from our research group at Origin and BPD, and talk a little bit about the evidence for treatments. I'll try and get my talk done in 15 minutes, so we've got time for questions at the end of the session. So Origin is Australia's it's a youth mental health service. It comprises of clinical programs, specialising in first episode psychosis and BPD, as well as sort of more generalist mental health care for young people, as well as a big research and translation program. And we've got some notable speakers like Professor Andrew Channon, who specialises in BPD, and Professor Pat McGarry and Alison Young, who talk a lot on ultra high risk and first episode psychosis. Thinking a little bit about what is a personality disorder, we know it's a personality structure that prevents an individual from achieving adaptive or helpful solutions to universal life tasks. It's not achieving stable or integrated representations of self or others, and without a capacity for intimacy, attachment, and pro-social behaviour and healthy relationships. It's a developmental disorder and must be seen in context of not normative development across the lifespan. It's a deviation from that. BPD itself, we know, is a pervasive pattern of characterised by instability in interpersonal relationships with others, and self-image and affects or changeable moods, and along with marked sort of impulsive behaviours which could be self-damaging, such as self-harm or aggression or drug use. Particularly, it begins by or even before early adulthood. It presents in a variety of contexts across a person's life. When we talk about adaptation and adaptive failures, definitely the presence of BPD disrupts normal development and fosters what we see as a vicious circle that further impairs achievement and adult role functioning. So those sort of problems that young people have, they carried through in life, and the diagnosis of BPD before the age of 18 can predict long-term problems in interpersonal functioning and achievement in work and financial security throughout the life frame. When we talk about BPD, we sometimes use this synonymously with severe personality disorder, because people with BPD, we know a diagnosis that demarcates a specific group with particularly high morbidity and mortality and a risk of particularly poor outcomes, even compared to the general population and other mental health disorders. In young people, we know that clinically significant personality disorder appears in that transition point between childhood and adulthood, which sort of has some variability depending on individual characteristics. But definitely the difficulties in personality disorder show continuity, that the traits and features people display in childhood usually persist into adulthood and can change in dynamic depending on different amounts of life stressors and other mental health disorders. And despite strong scientific evidence that personality disorder is across the lifespan, there seems to be a bit of a reluctance still to diagnose in younger people. But we know from evidence that you can diagnose as early as sort of 12 or 13 in some cases. Despite knowing all this, we know that BPD is quite common. It's got a prevalence in the general population somewhere between 1% and 2% in international studies. And what we think, actually, when you in psychiatric practice, that up to a fifth of psychiatric outpatients may have BPD. And indeed, it's that contact with psychiatric services where we feel that the seeds of the harm of personality and BPD are sown early in the course of the personality disorder. Indeed, a lot of that harm is highly from stigmatization. That stigmatization quite often comes from mental health clinicians, and clinicians can struggle to consider that sometimes these challenging behaviours and problems that are presented may be due to the nature of the pathology of BPD rather than the nature of the individual, which can lead to sort of treatment difficulties and treatment and the iatrogenic harm. When we talk more a little bit about psychotic symptoms and BPD, definitely this is a challenging group. It's quite a varied group, and we know that there's been awareness since the 40s of psychotic symptoms in BPD, and this group are known to be particularly poorly functioning and hard to engage, and definitely there's a lot of uncertainty regarding diagnosis and treatment, and no good clinical guidelines talking about that sort of co-occurring group. Quite often personality disorder is a secondary part of other guidelines on mood and psychosis. Symptoms are often contentious and dismissed and described with terms like psychotic-like or quasi-psychotic or pseudo-hallucinations, and it leads to these symptoms often being ignored or under-recognised and sometimes untreated, and which can cause a lot of confusion for clinicians and in patients. Despite this, we know they're quite common, and if you look in adult populations, up to half of adult BPD patients report auditory verbal hallucinations, but quite recently these psychotic symptoms, as I said, were believed to be brief, less severe, and qualitatively different from those that are considered in true psychotic disorders, as people say, such as schizophrenia. But when we look at a number of studies, I've been a lot more interested in this over the last sort of decades, that particularly auditory verbal hallucinations are indistinguishable from those in schizophrenia in adults. We've demonstrated a number of studies. But as I said, these are adult samples, but we need to think about the early intervention perspective, and especially important in the onset of psychosis and BPD are usually around the same time period in that sort of transition from childhood to adulthood in that 16 to 25 group. We know that BPD and schizophrenia, hallucinations are commonly long-standing and they can commence at a young age. We found that voices can commence around the age of 16 in BPD, around 20 in schizophrenia, and they're described as being phenomenologically quite similar. Some studies that have looked at sort of comparing these voices in adult populations with schizophrenia and BPD found similar experience of voices, including perceived location, maybe some differences in other psychotic symptoms such as delusions. But the BPD, the hallucinations had a very long duration, about 18 years, and the frequency is greater than daily for more than several minutes and caused a lot of distress, and maybe there is no difference in the characteristics between these two groups. So to answer that question, well, before we get there, actually, sort of a good quote was that the tendency when confronted with positive psychotic phenomenon is for the clinician in BPD is to make a diagnosis of schizophrenia or another psychotic disorder, or to dismiss the phenomenon, raising the question by resorting to a concept such as pseudo-hallucination. But this term pseudo-hallucination persists despite actually having no empirical evidence. This is a study that I want to present. It was done by a researcher, Maria Covetti, at our research clinic, and looked at exploring differences between different groups in a youth population between auditory verbal hallucinations. There was 3 groups, BPD and voices, compared to schizophrenia spectrum and voices, and BPD with no voices. And what we used to measure is using different sort of scales, CIRATS, PANS, and DAS-21, to look at is there any differences between these groups that we could see. About 68 participants came there, and if we look at the groups, they're pretty much similar. Obviously, there's more females in the BPD groups than the schizophrenia spectrum groups. They tended to be a little bit younger. But when you look at the comparison of the voices between groups on the CIRATS, in fact, if we look at the frequency, duration, location, amount of distress, disruption, and the perceived controllability, there was no difference between the two groups of schizophrenia spectrum, BPD and voices. The only difference was maybe more degree of negative content in the BPD and voices compared to schizophrenia spectrum. If we look and compare these groups for other psychotic symptoms as well on a PANS, maybe a few more differences come out, that definitely there was more delusions in the schizophrenia group. The BPD group had more hostility, and also the BPD group had less difficulty with abstract thinking than the schizophrenia spectrum group. So what can we say as a result of that? Well, we can say that definitely the BPD and voices group compared to schizophrenia spectrum, that the voices, the auditory verbal hallucinations, are phenomenologically indistinguishable. But there may be some other differences, that the BPD group had less severe delusions and difficulties in thinking. But the BPD group compared to the voices compared to BPD alone, that definitely youth with BPD and voices at higher levels of psychopathology compared to BPD alone and self-harm paranoia. So voices appear to be an indicator, perhaps, of a more severe variant of BPD, particularly in that group. So when we think about that, so what do we know about treatment for BPD and voices? Well, psychological treatments have been demonstrated to be helpful additions for interventions in psychosis, and definitely a lot of they've been looked at as CBT. They aim to reduce positive and negative symptoms and facilitate adjustment in young people experiencing their voices, and they're also helpful to make an understanding of how the voices sort of relate to the overall sort of formulation. And not only CBT, but other modes of therapy have been used in BPD, looked at dialectical behavioural therapy and cognitive analytical therapy. Pharmacological treatments are quite of interest. They're widely assumed to be unresponsive in BPD to pharmacological treatments, but there's only a small amount of studies that looked at this group, but they've generally to be shown to have a beneficial effect. But these groups that have been studied have mostly been mixed groups, not focused on a BPD and psychosis alone, but definitely shown to have some benefit. But paradoxically, and despite very limited evidence, almost sort of 2/3 of people with BPD get prescribed second-generation antipsychotics, but frequently it's for treatment of distress rather than psychotic symptoms. And often these groups have polypharmacy. Current practice guidelines, recommend against the use. However, a lot of treatment co-occurring problems is encouraged. So what we can say is there's little consistency in the treatment of auditory verbal hallucinations and BPD, and very few studies of the pharmacotherapy. One way of looking at this is to study this. And what we can say is that at our clinic at the moment, we are doing a trial called the Verbatim trial, which is looking at treating young people with BPD and voices, full threshold voices, with psychological therapy plus aripiprazole or placebo to see is there any differences. And we hope to present that sometime in the future. It's currently enrolling, and we're looking for about 140 clients. We're about halfway through recruiting at the moment. So even though there's an absence of evidence about the treatment of psychotic symptoms, that each patient needs to be taken into account with a risk-benefit ratio associated with either, before we delay or reject conventional psychotherapy for treatment of voices, which may, of course, expose our young people to adverse effects. And we also need to consider us advocating for psychological treatments with pharmacological treatments. So my conclusions being that psychotic symptoms, particularly voices, are common in BPD and maybe a marker of severity. That prompt diagnosis of psychosis and BPD is needed, and treatments including both psychological and pharmacological should be offered. And future research and education is necessary to reduce disability and promote early recovery, particularly in this youth population. I would like to acknowledge the HYPE research programme. We've all contributed to a number of studies, and some of the ones we've talked about today. But thank you very much for your time, and look forward to any questions.
Okay, thanks to Dr. Mullen. And we got about 10 minutes, and just open for questions. Any questions about from our audience?
Hello, this is Huaixuan Zheng from National Cheng Kung University. I think all four speakers gave excellent talks, and I enjoyed that a lot. I had a question for Dr. Mullen. Actually, I was in the IOP, the OSS program for about 2 or 3 years, and then went to Canada for their young psychosis program as well. So for me, one of the question is the overlapping between this group of BPD with psychosis. They seem to be many of them have mood swing a lot, and if you use the bipolar disorder, bipolar 2 spectrum to look at them, many of them maybe fit in there. And that's also the reason why I think aripiprazole might be helpful. So I'd like to ask how, Dr. Mullen, how your group to look at these two different phenomena and try to separate them or just treat them together.
Thank you very much for your question. That's a very good question. In fact, there's a question in chats as well, which is about something similar about mood instability as well as BPD. I suppose to say it's quite a heterogeneous group. It's sort of quite hard, especially early in a youth population. There's very limited sort of diagnostic stability in that group anyway. I think one thing that is key that we look to do is we do a very detailed assessment, a very detailed longitudinal assessment on entry to the service, using different points of time, using quite sort of detailed tools of mood timelines, going back at least 2 years of symptoms, with collateral information from family and carers. And we're quite cautious on sort of differentiating exactly that question. Are the mood swings that you see, do they have the character of affective instability, so as rapid changeable mood swings that are pervasive and persistent over time, as opposed to are we seeing a mood disorder? So is it something with definite state changes, with periods of hypomania and depression, with periods of stability in between? I think what we found is a very careful mood timeline over 2 years, and very careful history taking with sort of some reliable tools. I mean, we use a SCID informed diagnosis for BPD to inform whether something's over threshold or not for a trait or not. Leads to the diagnosis. I mean, I think sort of do some of the antipsychotics improve the mood swings for BPD? Sometimes, but not always. But do they work for bipolar? Usually. So quite often if somebody does present with psychotic symptoms in BPD and maybe goes down that path, we don't always treat with antipsychotics. Quite often they may have a trial of psychological treatment first. or combination treatment. Our philosophy is if we do a trial, at least 4 to 6 weeks of treatment, if it's making no change at all, we do go back and question our diagnosis again. And there's always the facility to relook at the diagnosis to see, are we making the correct diagnosis, rather than just treat and expose somebody to treatment for a long period. There's always the options to review and stop treatment if it's not helpful. I hope that answers your question a bit.
Thank you very much. It's really helpful. I hope one day that I can visit Origin sometime.
You're very welcome.
Okay. May I just questions from the chat room?
Hi. Am I audible? Can I ask a question?
Sure.
Hi, this is Dr. Bigya from Nepal. Thank you so much for a wonderful presentation. I really loved all the 3 presentations. My question is to Dr. Edward. We really have this challenge of having therapy sessions in Nepal due to various logistic reasons. The psychotherapies are not quite possible. So as we all anticipate that medicines are rampantly used for a borderline personality disorder to treat their mood instability as well as the psychotic symptoms, I was just wondering, with one statement which I saw in a presentation, like antipsychotics aren't quite helpful for the hallucinations in BPD. Can you please share your information on it?
Thank you for that question. So basically, is referred to the prevalence of quite often people don't get offered antipsychotics for psychotic symptoms because they have a diagnosis of BPDs. Antipsychotics are often withheld, or a trial of antipsychotics may be withheld because the feeling that they're not real psychotic symptoms because you have BPD. It's because of dissociation or because of trauma. You can't have genuine psychotic symptoms. So one of our work is that actually that's not based on any empirical evidence, that in fact the distress associated with the psychotic symptoms that someone with BPD experiences may actually respond to treatment. That's part of what our RCT verbatim is looking at the moment. Because we don't actually have, we have some theories about what causes psychotic symptoms in general. We don't really know. So how can we outrule someone with BPD for having psychotic symptoms just because they have these other sort of risk factors? But I do say that quite often that antipsychotics do get used in BPD, but it's mainly we feel for the side effects. I mean, people are put on sedative antipsychotics because they're sedating and because they reduce distress, not because they're actually treating anything. They're not sort of correcting any dopaminergic dysfunction or sort of, higher up the chain. We don't know. I think they're used for their symptomatic use as opposed to actually therapeutic use.
Thank you so much. I have my confusion on it because I really have come across few patients who have comorbid borderline personality as well as schizophrenia. So when we have such comorbidity, it is very challenging to plan ahead and treat the person. Thank you so much for your presentation. It was really very insightful.
Thank you. I'd like to direct you to our Religion's website in ORYGEN in Australia. Has a link to a lot of our evidence finders. So a lot of our papers that we've published on the subject and guidelines are actually available. So we've developed a lot of treatment conceptual frameworks for approaching BPD and psychotic symptoms in young people. So if you go onto our ORYGEN website, you'll find a link to all those sort of resources.
Thank you.
Thank you. Any other questions?
Hello, it's me again. I'd like to consult Professor Xi about the prospective memory. One issue is that I'm not sure if, because the depressive mood in elder stage sometimes might also affect their memory problems. So using the prospective memory of marker to to think about the possible future memory problems. Have you considered or have you controlled the baseline mood status? Are some of them may be a bit depressed, and the depression might also confound their memory function as well?
Yeah, thank you, Dr. Zhen. I think it is a very good question because the emotional status being a confounding factor that is primarily discussed in research in SCD. And so in most of the studies, we would include variables that assess like anxiety or depression, or like in Professor Wu's study, we also include worry into our algorithm to control it. And there has also been discussion about if we should exclude people with depressive symptoms from our participant group. And there was some discussion because it is unclear if depression is the consequence or it just goes with a dementing process. Probably it could be a part of it, or it could be like a reactive reactions from cognitive decline. So I think there has been some consensus that we only need to exclude those participants with diagnosis of depression, because in that case that would be too difficult to parcel out what is really affecting the phenomenon we're studying. But for those simply with tendency to be depressed, or they are more inclined to be worried, then we would include some questionnaires and use it as the controlling factors in the study. But yeah, I agree, that would be in a clinical practice, that would be one important factor to consider.
Thank you very much.
Okay. Any other questions? I think the time is just 2:30, and our schedule is just here. And thank you all the audience, and thanks all the speakers in this session. And wish you all have a nice afternoon in this session, in this symposium. Thank you very much. So we close this session.